to Focus on Health, a series of educational programs highlighting current health issues sponsored by the School of Nursing at Salisbury University. I'm Dr. MaryDiBartolo, Professor of Nursing at Salisbury University and host of the program. I welcome Dr. Sherif Ahmed. You are a pharmacy resident at TidalHealth Peninsula Regional, doing a one-year residency there as a pharmacy school graduate of the UMES Pharmacy School.
That's correct.
So you are here to talk about a very prevalent topic and the drugs that are used to treat it, that of heart failure. So let's first talk about what heart failure is and how prevalent it is. The numbers are staggering, and I think most of us know that as you age, many people will go on to develop heart failure. So talk to us a little bit about heart failure and its symptoms and so forth, and then we'll get in some of the drugs that are used to treat it.
Yeah, thank you so much for inviting me. So as you said, heart failure is a very prevalent disease state that we see in a lot of older Americans. As of 2018, they said the CDC records about 6.3 million Americans who are diagnosed with heart failure. Now, when we talk about heart failure, when we first talk about the risk factors, the most prevalent risk factor that you see in people with heart failure is hypertension, so people who have high blood pressure. And when people have high blood pressure for a long amount of time and it's not under control, if they don't see their doctors, if they're not taking the proper medication to control their blood pressure, what happens is the heart gets damaged. And when the heart gets damaged, it's harder for the heart to squeeze out blood to the body. And the mechanism of heart failure is that when the heart isn't able to squeeze out enough blood to the body, your body tries to compensate. You know, if your brain or if your kidneys or if any of your vital organs aren't getting enough adequate blood, they say, you know, hey, what's going on? I need to get blood to these vital organs, and they're going to try to compensate for that. You know, your body's smart, so it's going to try to increase how hard the heart squeezes. It'll try to increase the heart rate, how fast the heart beats. And what happens is your body does compensate, but that over a long amount of time causes more damage to your heart. And so the amount of blood that your heart ejects decreases even more. And when that reaches a certain point when your heart isn't able to pump out enough blood, then you're diagnosed with heart failure.
Yeah, it's like an unfortunate cycle because the heart is trying so hard to meet those demands. It actually enlarges, but in fact it gets weaker because it is a muscle.
Right, that's correct, yeah.
So what are some of the signs and symptoms of heart failure?
So the most prevalent signs and symptoms that you'll see is shortness of breath. You'll see people who aren't able to carry out their daily activities. So people who used to be able to walk up flights of stairs, once they start walking up 2 or 3 flights, they might notice they're short of breath. And it can progress even more to the point when people aren't doing any physical activity, they might feel short of breath. And there's a lot of different classifications on heart failure depending on how short of breath someone is, depending on the activity they're doing. So if they're short of breath during a normal activity, it's different than if they're short of breath during just menial laying down, no activity. So shortness of breath is something that you'll see a lot. Another sign that you'll see is when a person develops fluid buildup around, their legs or their arms. It's called edema. That's something that you'll see as well in people with heart failure. And when people develop edema, it can go into their lungs, and then that can make them even more short of breath. It's a very much a vicious cycle. So when we're dealing with people who are diagnosed with heart failure, we really want to try to give them medications to decrease the fluid buildup around them, try to help them recover their lung function, make it easier for them to breathe. So shortness of breath and fluid buildup are two of the biggest signs and symptoms that you'll see.
And of course, I know people may have heard the term pulmonary edema, meaning that fluid in the lungs, which can be a sign of worsening heart failure or a complication, and that can be very serious because, as you mentioned, it interferes with your ability to breathe and do activities. So the good news is we have some very good medications now. They've really come a long way from years ago when people had heart failure. And the goal here, isn't it, is so that people can take these medications and maintain optimal functioning at home and keep them out of the hospital. Because heart failure is one of those conditions, it's a roller coaster ride. It can be, especially towards the later stages where you're in and out of the hospital with worsening symptoms.
That's correct, yeah. And we see a lot of people coming in on a daily basis when they're short of breath. and their regimen isn't properly optimized, so their ejection fraction is still lower, and they'll come in with pulmonary edema, like you said, shortness of breath. And it is a challenge to, help the people who are in the hospital, because if they're not able to take the medications, if they're not adherent, then they'll just come right back. So it's a big challenge facing us.
And sometimes it can be a cost factor for those medications, or they're having side effects. Mm-hmm. And if they don't report it to the doctor, then he or she wouldn't know, the provider. And there's other options for people to take different medications that they may not have, such side effects. Plus, you also mentioned ejection fraction. Just to clarify, that means like how much blood the heart is pumping out. It's a test to measure that. That's
correct. Yeah, it's the amount of blood that the heart pumps to the body. There is a diagnostic test that you'll do in the hospital. It's called an echocardiogram, where they it's just a diagnostic test that is able to predict the ejection fraction once it gets below a certain percentage. Usually we're looking at around 40%, then you're diagnosed with heart failure with, specifically it's called reduced ejection fraction. So when your heart isn't able to properly pump out enough blood to the body.
Right, and we need to get blood to our kidneys and brain and those important organs. Okay, so let's start with, there's a couple different classes you wanted to go over. Let's start with the ACE inhibitors. So tell us exactly how they work and what are some of the primary drugs in that category, along with any side effects people may have.
Yeah. So ACE inhibitors, the ACE stands for angiotensin converting enzyme. These are one of these drugs in a bigger drug class that affect the renin-angiotensin-aldosterone system. And I know that's a mouthful. It has to deal with blood pressure management, specifically in the areas of the kidneys. So what happens is when your heart isn't able to pump enough blood, specifically when the blood isn't able to reach the kidneys, there's this mechanism that kicks on that helps to try to compensate. And that mechanism is part of the renin-angiotensin-aldosterone system. So what ACE inhibitors do, as well as angiotensin receptor blockers, what ARBs do, is they work specifically on that mechanism. So they help your body try to decrease that compensation that they have. It'll decrease the amount of fluid buildup. It'll also decrease the strain on the heart as well. So primarily works on your kidneys, but it helps your body out as a whole. They're the preferred drug class, ACE inhibitors, because they do have mortality benefits. So people who take ACE inhibitors are shown that they will live longer if they have heart failure compared to people who don't take ACE inhibitors.
I know they are amazing as a class of drugs, and they're used quite a bit for blood pressure management. And of course, I think most people don't know that the kidneys do play a major role in blood pressure management, maintenance. So I know you want to talk about two of the drugs in this class that are commonly used for heart failure.
Yeah, I think one of the most common ACE inhibitors that people will see is lisinopril. The brand name is Zestril. Really nice way to know the class of medications is if a medication, the generic ends in pril, P-R-I-L, it is an ACE inhibitor. Luckily, there are no exceptions. If you see a medication that ends in pril, it is an ACE inhibitor. And that's probably one of the more common medications that you'll see. But right now, if you turn on the TV, there's a lot of commercials for this new drug called Entresto. That's the brand name. The generic is sacubitril and valsartan. And valsartan is another one of those drugs that work on that renin-angiotensin-aldosterone system. It's classified as an ARB, an angiotensin receptor blocker. This one is a little bit newer, and there has been shown that maybe the data on it saying that it might be preferred over other medications. And that's why it's getting a lot of mainstream popularity right now.
So what exactly is in Entresto, which is the brand name?
So Entresto is one of these newer medications. It is a combination drug that contains sacubitril, which is this natriuretic peptide, and it also contains valsartan, which is an angiotensin receptor blocker, has very same mechanism compared to your ACE inhibitors. And this newer drug was put in combination, and a lot of the data is showing that it might be more beneficial than someone who's just put on an ACE inhibitor by themselves or an ARB by themselves.
What side effects can people have?
So specifically with ACE inhibitors, the most common side effect you'll see is this dry, irritating cough. And that has to deal with the mechanism. There's a compound that if it gets into the lungs, it can cause this dry, irritating cough. Luckily, if someone does have this cough and they're unable to take an ACE inhibitor, we are able to switch them to an angiotensin receptor blocker, an ARB. The guidelines recommend both equally, and ARBs aren't going to have that side effect of that dry, irritating cough. And that's probably the most prevalent side effect that you'll see.
Right. So let's move on now to beta blockers. They've been around a long time, but we have newer ones now that seem to work very well compared to some of the old-time ones like propranolol. So what do you want to, how did the beta blockers work?
So the beta blockers work primarily on the heart. There are these beta receptors that are located all over your bodies, and there's a whole bunch of different beta receptors. Beta 1 receptors, beta 2 receptors, beta 3 receptors. But here we're primarily going to focus on the beta 1 receptors, which are located in your heart as well as your kidneys, and they're going to help decrease the contractility, so how hard the heart squeezes. They also decrease the heart rate as well. But what's special about beta blockers is they have the same property that you see in ACE inhibitors and ARBs, where that compensatory mechanism that you see in the kidneys, this is buildup of what's called renin. Beta blockers also block this compensatory mechanism, which is why the guidelines show that beta blockers also have mortality benefit in patients with heart failure. So we have two really good drugs, both have mortality benefits.
And what are some examples of the drugs in that category?
So beta blockers are a little bit specific. Unlike ACE inhibitors and ARBs, where you can use any drugs in that drug class, for beta blockers, the guidelines only recommend 3 specific beta blockers. There's metoprolol, which you'll see as Lopressor. There is carvedilol, which you'll see as Coreg, and you'll see bisoprolol, also known as Zebeda, are the 3 big beta blockers that you'll see for patients with heart failure.
Any side effects to those?
So a lot of the side effects that you'll see have to deal with their effects on the heart. So if you have palpitations, if you feel lightheaded due to decreased blood pressure, a lot of things like that. There is one other very specific side effect for beta blockers is it includes patients who are diagnosed with diabetes. People who have diabetes, if they become hypoglycemic, so if their blood sugar drops to a certain level and they're on a beta blockers can mask some of those symptoms of hypoglycemia, which can be very scary because if a patient is, becomes hypoglycemic, they know the sense of, heart rate, sweating. Beta blockers mask those, so that can be very dangerous.
Well, and a therapeutic piece of the beta blockers is they slow down the pulse, so you do have to keep an eye on your pulse rate so it doesn't get too low for some reason, but that's a therapeutic effect. It's resting the heart in a way. It doesn't have to pump so fast, so hard.
Correct.
So now, do we usually give these in combination, an ACE and a beta, or they'll start with one?
So usually you'll see that a patient is started on an ACE inhibitor or a beta blocker first just to see how they tolerate it. It gets a little bit tricky if we start both of them at the same time because we don't know if there's going to drop the blood pressure too quick. So you'll see usually one is started first. You'll see how the patient tolerates it, if their blood pressure is fine, and then if it is, then you'll start the next agent.
And typically that would be adding the beta blocker to
Correct.
the mix. Okay, and I know you wanted to talk a little bit about loop diuretics, which is furosemide or Lasix basically. That's been around since the dawn of time, it seems, and it was the primary drug for years until ACE inhibitors came along. But we still use Lasix, don't we?
We do, yeah. You see a lot of patients on Lasix. And like we said, how people who have heart failure, they have this buildup of fluid in their bodies, and especially if it gets into their lungs, it makes it harder for them to breathe. It makes it harder for them to carry out daily activities, and that's where loop diuretics come in. Loop diuretics help relieve the body of all this excess fluid. And it's mainly used for symptom control. So unlike ACE inhibitors and beta blockers, loop diuretics aren't shown to have benefit in mortality, but it helps patients go about their daily lives.
So the ACEs and beta blockers, we can give those every day, whereas Lasix is more for if you're having more of an issue, sudden increase in fluid retention. And the downside of Lasix, though, if it's used in stronger doses, you lose potassium along with that when you're increasing your urination or diuresing. So they may need some potassium supplementation during that time.
Yeah, it's important that once they get started on a loop diuretics to follow up with their primary care doctor, and they'll run tests to look at their potassium, see how fast it's dropping, and if it's dropping a little bit too quickly, some oral potassium supplementation would be very helpful for those patients.
So, and then the last class you wanted to mention was the aldosterone antagonist, and that would be, I'm going to let you pronounce it.
So the generic is spironolactone, and the brand name is Aldoctone. This is very similar to furosemide and Lasix, as it is also a diuretic, but this one, the special property about this one is it's a potassium-sparing diuretic. So if you have a patient who is on furosemide multiple times a day and you're worried about their potassium falling a little bit too low, Aldoctone will be beneficial for that, help raise their potassium. Spironolactone also has mortality benefit in patients with heart failure. So you'll see patients who can tolerate it after they are an ACE inhibitor and a beta blocker. You'll find that they'll get put on Aldoctone because it is beneficial for them in the long run.
So is that to just use, for spot problems, or can people be on Aldoctone every day along with the ACE and the beta blocker?
People are usually on it all day. Yeah.
Okay, very good. So let's wrap up by talking about some of the important things to remember, overarching points about how to manage heart failure, how to stay out of the hospital, and of course, most importantly is keeping the blood pressure under control and being diagnosed when the time comes so that you can be put on this regimen that can help control heart failure.
Yeah, and it all boils down to, knowing your body. So if you are a little bit older, making sure that you're regularly checking your blood pressure. High blood pressure, if left uncontrolled, can lead to a multitude of problems, including heart failure. So if you're able to get ahead of it, if you're able to monitor your blood pressure, if you notice that your blood pressure is getting a little bit too high, making sure you reach out to your primary care physician or a doctor so that they can prescribe you blood pressure medications. Try to get it all under control. Also, going to your doctor if you feel shortness of breath that's been developing over time, if you have fluid building up around your legs and your arms, just making sure you know your body best and reaching out to a doctor if something changes.
Right, it's important once you get on medications is to let the doctor know if you're having certain side effects so they can try different medication, because we do have arsenal of medications now. You said that you see your primary care provider. I guess early on you may see that person every 3 to 6 months until you can get your medications adjusted.
Yeah, so it's important that when you're first diagnosed with a heart failure that things change rapidly. You're getting put on medications, sometimes multiple medications over a certain amount of time. So when you're seeing your primary care physician, it might be a little bit more frequent during the initial diagnostic phase, every 3 months, every 6 months. And then after you get your heart failure under control, after you see them every 6 months and your body is fine, then you might be able to spread it out to annual visits.
So earlier on you mentioned risk factors, with the primary risk factor for heart failure being high blood pressure. But we also know there's things that we can do in terms of lifestyle modifications to help with that problem, which in turn would help with heart failure, and that would be things like don't smoke, proper diet, exercise.
Yeah, lifestyle modifications are things that pharmacists always preach first. Before trying any medications, we want to make sure that we're able to do everything we can to help the patient before putting them on a medication. So that includes exercising 150 minutes a week if you're able to. A heart-healthy diet, reduce the salt intake, reduce the fast food, reduce the soft drinks, things like that. Don't smoke. A lot of these lifestyle modifications are beneficial and they make a huge drastic impact. If patients are a little bit overweight, then losing the weight, a lot of these things will help your body in the long term, not only with hypertension, but as a whole. And it can prevent you from developing high blood pressure, heart failure, and being put on these medications later down in the long run.
Yeah, good point. I know 150 minutes sounds like a lot. That is the recommendation, but there's so many different activities that count as exercise, including walking. You don't necessarily have to run or do anything ultra strenuous, but just moving, staying active is all helpful. Well, Sherif, thank you so much for being on the program. I know you have a busy schedule, but you provided such wonderful information.
Thank you so much for having me. This was great.
And thank you for joining us for this edition of Focus on Health here on PAC 14.